Hello friends, good morning. Now today we are continuing our previous lecture of diuretics. That was, we have talked about the drug acting on proximal convoluted tubule, on distal convoluted tubule, on ascending loop of Henle. Now we could talk about the collecting ducts and collecting tubule, the drugs acting on it, and little bit of physiology. Okay, so we know this is the, if you take the cell from your collecting tubules, then there is a principal cell, alpha collected cell, intercollected cell, and beta intercollected cell. The main is principal and alpha intercollected cell. You know, when the urine is coming out, what happened? The urine, now lots of sodium, water has been absorbed. Those sodium which is going out, this part of the tubules, what they will do, they will try to absorb this sodium. Okay, and in the exchange of sodium, what happened? There will be creation of negativity to the lumen. For that, they will excrete the potassium, as well as if there is more, if the negativity has not been neutralized, then they will secrete the hydrogen by the ATPase dependent form. Are you getting my point? Main thing is that, look, our main aim of this part of the tubule is to absorb the sodium and water. Now, water will be absorbed in the presence of ADH. ADH is secreted from the posterior pituitary. So, if there is decrease in volume, increase of osmolarity, then this ADH will be released, and this, in the presence of ADH, this water will get absorbed. Okay. Now coming toward the sodium that is lost in your urine. Now what body sense that sodium is going out, so it will try to reabsorb the sodium. But you know that it have to maintain the charge neutrality. So when it absorbs the sodium, there is a luminal negativity, and for luminal negativity, that what it will do, it will secrete potassium first. If it is able to neutralize the negativity, then it's fine. If not, then again when the urine goes to the alpha intercalated cell, the hydrogen will be secreted and try to neutralize the negative luminal activity, negative luminal charge. That is main important point. So potassium will be excreted. If potassium is low, then direct hydrogen will be excreted. If potassium is not low, then potassium will be excreted to the certain extent. After that, they will stop and hydrogen will be excreted. Means it is not that potassium will be go and you will be severe hypokalemia and arrhythmia and death. That is not the situation. Although hypokalemia if will occur, but if you are not going to correct, then they will have the complication. But by this process only, you will not going to have a severe, like 2 or less than 2 will not occur. Even 2.5, okay. So the hydrogen will be secreted. Now the main role is of aldosterone. Aldosterone is the main player over this part of the tubules. What do? Aldosterone has a receptor, that is a mineralocorticoid receptor, that increases the activity of the sodium potassium ATPase form. So it increases the activity of this form. Okay. So sodium is gone out, potassium come in. Now this increases the activity of this. Sodium goes out, there is negative sodium in the cell, sodium is reabsorbed. It also increases the conductance of your potassium channel, it increases the conductance of your epithelial sodium channel. Okay, then it increases the activity of this potassium hydrogen ATPase form. So it is acting on everywhere. Its main aim is it increasing this activity. Sodium is gone out. Now sodium is less in this. So sodium is less, then what will happen? The sodium will come in. Sodium will come in, it has to secrete out the potassium. Potassium will go out. Okay, now here hydrogen will come out. This is the normal physiology. The main aim of the aldosterone is to reabsorb sodium, and in process of reabsorb sodium, it has to excrete the potassium. Okay, now what we will do? Now we will add 2 kind of drug. One will be the not aldosterone blocker, which it will receptor blocker. If we block the action of the aldosterone by blocking the receptor, and that is known as the, we are talking about potassium sparing diuretics. And potassium sparing diuretics are 2 kinds. One is the aldosterone receptor blocker, and another is a sodium channel blocker. First we talked about aldosterone receptor blocker. If we block the aldosterone receptor, then the activity that has created by the aldosterone, that is increased activity of your sodium potassium pump, increase conductance of your potassium and sodium channel, that will be blocked. Since that is blocked, no more sodium is reabsorbed. No more sodium is reabsorbed, no more potassium is excreted out. Okay, so in this case, hypokalemia can be prevented and diuresis can be maintained if you excrete the sodium. With sodium has a capacity to hold the water. Now water and sodium will be lost and diuresis will be maintained. Although this is known as the low ceiling diuretics. This is very low power. Okay, high ceiling is furosemide group of diuretics, low groups of diuretics, medium is thiazide group of diuretics, and low ceiling is your potassium sparing diuretics also. Okay, so potassium sparing means it is sparing the potassium. Potassium is not lost in the urine. In all the case of diuresis, you have found that potassium is lost due to sodium has been diuresis, and because of that potassium was losing and hypokalemia is occurring. Now if we use this diuretics, this will not lead this activity of this part of the tubule, and since there is no more sodium absorption which was losing in the urine, then no more hydrogen will be potassium and hydrogen will be excreted out. So this is called potassium sparing, spare the potassium. Okay, now talking about aldosterone receptor, if you block the receptor, then the activity over this and this 1, 2, 3 and 4, this all will be not occur, and if it is not occur, then potassium will not be excreted, but sodium will be lost in urine along with some amount of diuresis occur, around 3 to 5% you can see. Okay, so diuresis we can, and the aldosterone receptor antagonist drug are spironolactone and allopurinol. Okay, these two are the drugs that will go and block this receptor and maintain the diuresis. Although you have to know that this diuretics, this is very small amount, so we will use this diuresis in combination, diuretics in combination with other like high saline and medium saline, that is loop diuretics and thiazide group of diuretics. In combination, what will happen? Diuresis will be enhanced, plus they will prevent the complication like hypokalemia. Okay, that is the major thing you have to understand. Now talking about aldosterone receptor, you have known there is another process by which we can maintain. If you can block this channel, now if sodium will not be absorbed, then how much activity it is increased by aldosterone, how much conductance has been increased by this, how much hydrogen ATPase activity has increased by aldosterone, doesn't matter, because unless sodium goes inside, there will be no negative luminosity. If no negative luminosity, then what? The potassium is not need to excrete it. So if you block here, all the action is automatically although going on, but it is no value. Now it will be blocked. Okay, since sodium will not go, potassium will not come out, so there will be no other action. Okay, although sodium is lost with along with water will loss and diuresis will be maintained. So this is another good way to prevent your potassium loss in the urine, prevent your hypokalemia, and so it is also known as the potassium sparing diuretics. And the direct sodium channel blocker are priam-carrying and amiodarate. Okay, so when look, the spironolactone and allopurinol, I'll come there. Their mechanism actually you have understood. Spironolactone and allopurinol, they are the receptor blocker of the aldosterone, whereas the sodium channel blocker are priam-carrying and amiodarate. They go and directly block the sodium channel. What are the clinical use? Clinical use will be hyperaldosteronism. Aldosterone, if activity is more, then it will lead to the loss of your potassium loss more in the urine. So either you block here, either you block here. Both way you can prevent the potassium loss from in the urine. Okay. Then potassium depletion. If there is a potassium depletion, obviously you will not take risks of loss of potassium from yourself. So you need to give this, at least your potassium will be present in your blood. Then heart failure it used in the combination of your other diuretics. Hepatic ascites, that is spironolactone. Look, hepatic ascites is there is a loss of fluid into the peritoneal cavity. There is lack of what? Lack of blood volume in your blood. So there will be activation of renin-angiotensin-aldosterone mechanism, RAS, RAAS. Since aldosterone is released, now aldosterone activity will increase, and that will lead to sodium reabsorption but loss of potassium. And since there is a loss of potassium, that will lead to hypokalemia. And if you remember, in hepatic failure or liver cirrhosis patient, hypokalemia, there are a lot of risk factors, among which hypokalemia is one of the major risk factors for hepatic encephalopathy. Hepatic encephalopathy, that is nervousness and other feature of your encephalopathy will develop, and that can be even life-threatening. So this hepatic ascites, spironolactone, that is potassium sparing diuretics, is very useful, and it is very, very useful. You have to make stress of it. You will know when you will be a gastroenterologist or hepatologist. Then comes to the nephrogenic diabetes insipidus. Again, the process I have explained you in distal convoluted tubule about the use of thiazide groups of diuretics for nephrogenic diabetes insipidus. Same is here. Amiloride will try to loss the water. The loss of water is less, but the other proximal tubules will get sensitized and absorb more and more water. So, although there is a insipidus, diabetes insipidus, more urine is lost. If you use the diuretic, that will negative feedback and reabsorb more water and further prevent the loss of water from your urine. That is nephrogenic diabetes insipidus. And obviously for anti-androgenic effect. Okay. Now coming to the adverse effect. If you are talking about adverse effect, obviously if you are not excreting your potassium from your urine, then your potassium will be made sometimes increase, and that will lead to the hyperkalemia, can lead to arrhythmia. There will be endocrine effect with spironolactone. This is a steroid group of drug. So there will be a gynecomastia and anti-androgenic effect. Okay, so this gynecomastia is very important. Why important? Because this is actually very painful gynecomastia, and it is a characteristic of aldosterone, that is spironolactone. Okay, so spironolactone use can lead to gynecomastia. This is especially a spironolactone side effect. So painful gynecomastia. So in this case, you may go to this triamterene and amiloride for using a potassium sparing diuretics if a patient develop painful gynecomastia. This is not the side effect of your sodium channel blocker. It is a aldosterone receptor antagonist. So sodium channel blocker can be used in combination, or you can use wherever you are indicated. Okay. In case there is a side effect like gynecomastia and anti-androgen effect, which are the effect of your aldosterone receptor antagonist. I hope you understand. This is a very simple but very important concept. If you know it, it is very useful to in your daily life as also, while dealing the patient in the clinics as well as dealing the test questions. Okay, thank you.